The event is organised in collaboration with the Arts for Dementia Therapy Network Northwest, which have been working very hard over a year and a half to raise funding as well as ideas to promote arts activities, visits to similar organisations, providing training programs for people living with dementia and carers as well, and also members of the public who needs to learn more about dementia and how they can associate with the arts and media to help them, help their well-being. Before the program begins, can I invite the Rochdale Mayor, Councillor Srindra Beyond, and the Mayoress, Councillor Cecile Beyond, to say a few words.
This is sort of a very important event. I know that in my family, distant relations have had people who have had dementia, and how devastating it can be to the families and to the relations, how it affects it. One of the most important things that we need to understand is what Mohammed is doing here, is to actually become aware of it. You know, how it affects people who suffer from dementia. And it's not an easily understood issue that people suffer from. And it's so important that people like yourselves who are involved in this, you can make other people aware of dementia. And I feel very privileged that I've been invited to a number of events with dementia issues.
I could see a lot of familiar faces here today. Last year I was the Cabinet Member for Public Health and Regulation, so I was quite involved in public health issues, and I started out on the networking panel that Mohammed is advertising, and it is quite a high-powered group of people who know the issues, and it is well worth being a part of that networking group.
I'd like to introduce Sue Nielsen now, a dementia champion. She was formerly dementia coordinator with Oldham Clinical Commissioning Group, and she's an active campaigner creating dementia-friendly communities across Oldham. She's worked on social inclusion agenda and supported those who have not got a voice, enabling them to be heard. Sue Nielsen.
When you hear the word dementia, what do you immediately think of? What comes to mind? Anybody? Just any word.
The elderly.
Sorry?
The elderly. The elderly.
The elderly.
Forgetful.
Forgetfulness.
Confused. Confused.
Sorry.
Confused.
Confusion. So, you know, it's quite complex really. It's not a single strand. It's quite a complex issue, and it needs to be understood more, just as you just said that. If someone was to actually describe you with these kind of words, you for example, if you were described as having stigma, discriminated against, confused, forgetfulness, etc., would you like it? Why not? Why? Yeah, it's very negative, isn't it? All these words are very, very negative. And in fact, Dementia Friend is all about trying to raise awareness so that it's more readily understood, and in so doing, more accepted and more positive.
We've now got Robin Parker, who's going to read a monologue.
Well, that's it then. She's gone. I shouldn't complain, it happens to us all, we have a good life. 3 lovely children and grandchildren just keep coming. I tried to do my best to help and advise them, but, you know, it would have been nicer with the wife around. But sadly in our case, it was impossible. I keep trying to think when it first started. It's hard to say, but I do remember a couple of things. Like when she couldn't find a person, it turned up in the fridge. We all thought that was funny and laughed about it at the time, not even thinking what it really meant. Then she kept asking me about things that we'd already discussed earlier in the day. Next, we started to run out of things at home. She was forgetting to put them on the shopping list, and sometimes she would forget to buy things that were on the list. Okay, that was one scenario. Now, given some of the things that Sue was talking about earlier, can you think of any way that that situation could have been improved? Any ideas? Bit of help earlier on, yeah. How could that have worked? Early diagnosis, medication. What about dementia advisors? Yeah. So if say a dementia advisor had come in right at the beginning, perhaps they would have been able to look at things much more differently, pick up some of the things that you were talking about, Sue, and enable her to have a richer life and therefore not be so irritable and losing a temper because she felt more comfortable.
Now we have another one of our guest speakers, Dr. Julian O'Kelly, in the Art and Science of Music Therapy. Dr. O'Kelly has worked in palliative care, dementia and neuro-rehabilitation as a music therapy clinician, manager, educational and researcher for the last 15 years.
Talking about the art and science of music therapy, we don't often think of science when we talk about music. We think of perhaps something that helps us get up in the morning, that helps us in the gym, that brings back memories, and we'll get very much onto the memories later. But there certainly is a science to it, and it's something that's very much evolving at the moment, something I'm very excited to be involved in. Well, let's tell you more about it. And if you look at them, they're the red dots on that wonderful brain up there. Red dots that are actually quite deep set in the brain. They're not in the peripheral areas of the brain, and these are the areas that get damaged with head injuries, that shrink in the case of certain dementias. But these areas that process music are often more intact, and this is where we process music as well. A chap called Indira Patel has put together something called the Opera Hypothesis for Language Development. And that's an acronym which tells us which things are going on when music is driving neuroplasticity. You have an overlap. The anatomical areas that deal with language are also activated by music, so it can improve language just by that overlap of areas. When we play music, when we listen to music, when we're involved in any sort of music, there's a precision involved that is more involved than there is in language. And by putting demands on precision, you drive neuroplasticity. And of course, music evokes emotions and makes us want to repeat the experience. We often go back to that favourite tune of ours to evoke a certain memory, or sometimes it might surprise us. When we're practicing, we're repeating something again and again and again and activating our attention. And when you draw all these different thinking processes together, it's no surprise that you drive neuroplasticity, the brain's ability to repair itself. Various conditions like cancer, we're getting much better at curing and fixing. Dementia, we've got a long way to go, and so it's most likely going to be a much larger slice of the care burden in the future. So for instance, in Europe, you've got 7.2 million, which is forecast to increase to 16.5 million by 2050. Now, dementia care costs a lot more than cancer care, 3 times as much. But investment in research is, shame upon us, 1/6 of the total that is the cancer. So there's something very fundamentally wrong there, isn't there? But there are new treatments that are being looked at the moment that can reduce the burden and costs of care for both the NHS and the individual carers. And I've noticed there's some great carer initiatives here that can help carers with the burden of dementia. And I think music therapy is going to play an important role in the future.
We're going to have a few people who've got personal experience talking about dementia now. First we've got Alan Farr, who's an IT care for his wife Linda.
I find it so difficult to suppress and hide the irritation I feel when things are repetitive, when you ask one thing and then I have to go through 14 answers of where to do it, how to do it, what to do with it, etc, etc, etc. And I'm in the middle of making tea. And I get irritated and sometimes I lose it. But more than that, I think, again, think about some of the things the doctor was saying, even if I say the right things, it's not always obvious that I'm saying them, and I can say something very nice with an irritation in my voice, in me, etc. And I think that's the worst thing, because that comes between us, my irritation, and I know that it's my fault and not hers. So that's something I have to deal with as a carer.
Next, I would like to introduce Balkis Akram from the Gateway Leisure Services.
My name is Balkis and I'm a carer for my mum who's 95. And as time comes, I know she gets confused and she got bad dementia, but things start getting wrong way around because as time comes, I start getting confused with a lot of things. I have to remind her for her medication, for her dressing up, putting things wrong way around, a lot of confusing, what day is, and everything. It's a matter of age as well, but I do care 24/7, even if she sleeps, I don't sleep. Because she gets up, she can't tell what's it, night or day. She gets up through the night when it's my time to go to sleep, stepped on walking. Hey, I can see the sunrise, it's moonshine looking through the window. And she thinks it's the daytime and it's really, really bad. She don't understand things like that, but she do have a quite good memory. When Pakistan was separated from India, she remembered every and each thing. She'll tell us the story for all day, but she forgets where she put the toothbrush. Well, life goes on. I do love her and care her, because you never know what's the day going to bring for myself in the future. So maybe if I care for her in the future, my children might think about that and care for me.
A big element of our programme of work is actually working with services, with commissioners, with GPs, around making sure that people who have symptoms that are looking like it could be dementia are actually assessed and referred to as necessary to specialist services, and that GPs in particular in primary care are equipped to recognise what's actually happening to that individual and their family. Because timely diagnosis really can and does open the gateway to good support for people living with dementia. It certainly should be doing that.
What we have identified is that all the researches that were done with Caucasian, as we might call it, in terms of ethnicity. And few researches were done on Pakistani background, Asian background, Jamaican or African. And when we talk about African as well, we talk about big map, West African, Southern African. So it's a big challenge there. As I said from the beginning, in my intervention earlier on, is as a community, as a little group of community, what do you have as access to bring on the table to fill that gap? We won't wait for our fellow researchers, white, Caucasian, to talk about us. So this is where the gap lies. The gap doesn't exist because they are, as we call it, racist. The gap is just there because there's no resources, there's nobody to come forward saying, this is scientifically what we have as an issue. And this is why we're coming now. And the gap in the service in the whole England or in the whole UK is just about, not because of a race issue or people not willing to do, just because we haven't got that sort of ability to come and engage with the community. As he said early on, if in a mosque, the order is not given in a mosque for people to engage in just statistical questions, people don't fill that up. I've been to university with my fellow white. They are very interested in what's going on, and every form they feel it. My fellow African, they don't feel it. How do we know there is a problem? We just there say black didn't matter, but what have we done as community to fill that gap?